Hello everyone, I am going to show an interesting case. This patient presented with a large abdominal mass, and after a evaluation we are posting this patient for laparoscopic surgery. After introducing the laparoscopy, we could see a large tumor predominantly attached to the greater omentum. So more than 90% of its blood supply was derived from the greater omentum. It was closely related to the descending colon, and it was getting some of its blood supply from the vessels of appendices epiplaike, and these smaller vessels got enlarged because of the tumor size. And you can appreciate a pulsating vessel which is arising from the descending colon appendices epiplaike and supplying the tumor. There is a good gap, very good gap between the descending colon and the tumor itself, and at least more than a centimeter distance was there between the tumor and the cirrhosis of the descending colon. So we are sealing the vessels which is arising from the descending colon and its appendices epiplaike carefully and individually, and dividing with ultrasonic scalpel. So you can see a very nice distance between the descending colon and the tumor. So now we have almost completely detached the blood supply from the descending colon, and the tumor is completely detached. So this is a completely detached tumor, and the capsule is intact, and there is little bit of blanching on the cirrhosis of the descending colon because of the energy source like ultrasonic CS used during the division of the vessels. So this we want to reinforce with the seromuscular to seromuscular suture. We used 2-0 PDS suture, and it was a continuous 2-0 suturing. Gastrointestinal stromal tumor is the tumor which is arising from the interstitial cells of Kajal, and that is the motility regulating cell, and it can behave like a benign tumor to an aggressive malignancy depending upon the size and the proliferation index. The main treatment for gastrointestinal tumor is stromal tumor is excision with negative margin. So you have to excise the tumor with negative margin. And another important point during excision is you should not breach or rupture the capsule of the tumor. So this is sometimes it will be a very friable tumor. So you have to use extreme caution in order to prevent rupture of the capsule of the tumor, so that there will not be any recurrence in the post-operative period. Gastrointestinal stromal tumor, otherwise called GIST, arising from the omentum is very rare. Only few cases has been reported in the literature, and this is one of the case which we came across, and the same was removed by laparoscopic approach. You can see because of the proper usage of energy source, there is absolutely no bleeding, and this patient incidentally had right ovarian cyst. This patient had undergone previous hysterectomy. The gynecologist has advised to remove the ovaries along with the tube on either side, and that's what we are trying to do. You can see the course of the ureter. The instrument is touching the course ureter, and you can appreciate the peristalsis. While doing oophorectomy, You have to stretch the infundibulopelvic ligament nicely. You have to bring the pedicle more medially away from the lateral pelvic wall so that there will not be any injury to the structures like a vessel or ureter. And while sealing, you have to seal the vessel at multiple places so that there will not be any chances of post-operative bleeding. So seal at least 3 places, and while dividing, you go close to the specimen side and divide the pedicle. You can appreciate the main vessel has already been sealed and divided, and what we are doing is just division of the peritoneal attachment. So now we are done with the division of the infundibulopelvic ligament. There is a strand of attachment to the bladder peritoneum that is also carefully laced in order to free the specimen. This is the right tube and ovary. Similarly, we are lifting the left side tube and ovary, and we are inspecting the course of the left ureter, that is the left ureter which we are seeing. And now again the same step is repeated. Use a vessel sealer device. If you are not having vessel sealing device, you can use a bipolar and seal at least this patient had a smaller ovary, relatively atrophied ovary, so the vessels are very small than thin. So if the ovarian tumor is very large, you can seal with vessel sealing or a bipolar device and divide it with an ultrasonic CS. Again, 2 or 3 places sealing, and cutting is done close to the specimen. As you go and progress, you can appreciate the divided round ligament on the left side. That is a round ligament which you are seeing. Now, almost we have come to the end of the left salpingo-oophorectomy. Once this is done, then both the specimens will be put into an endo bag for extraction. So this is the freed specimen, both right side tube and ovary and left side tube and ovary. And this is the port placement. And this is the endo bag which is kept inside. Both the tubes and ovaries are kept inside the endo bag. And by holding the attachment, we are putting the gastrointestinal stromal tumor also into the bag, and we are extracting the specimen through a small phalangeal incision. Thank you very much.